So we've really seen an explosion in knowledge about CLL over the last decade. We've come to appreciate that the B-cell receptor is critical to the survival of CLL cells, as well as the importance of BCL2 in protecting CLL cells from undergoing apoptosis. So I think in the last few years we've now seen these new agents come into the clinic with a couple of new FDA approvals and several new agents on the fringe of approval, and it's really transforming the field. I think this first step of sort of monotherapy approvals is really just the beginning, and now the real excitement and fun comes in combining these agents in rational ways. They typically have non-overlapping toxicities and hopefully complementary efficacy. So I think with some of the agents so far we've seen mainly partial responses, and so I think by combining the agents we hope to get deeper and more durable responses. And I think for older patients we're hoping to move away from chemotherapy toward a chemotherapy-free approach, and I think hopefully even with monotherapy and in some cases with combinations of the novel agents, we'll be able to do that for our older patients. For our younger patients with CLL, they still have a long time horizon, maybe 30, 40 years ahead of them, and so we've actually at our center been looking at combinations with chemoimmunotherapy, for example, combinations of duvelisib, the PI3 kinase inhibitor, with FCR, as well as a study of ibrutinib with FCR. And these are targeted toward younger patients with CLL and using the MRD, or minimal residual disease rate in the bone marrow, as a surrogate endpoint, so that we can hopefully detect these deep responses early on as a predictor of hopefully overall survival for these patients.